In the previous video, bile duct stones explained, we explored how bile duct stones behave, how they form, how they slip into the bile highway, and how they cause pain, jaundice, fever, and even pancreatitis. Today, we shift gears. If the bile duct is a main highway and stones are cars parked in the middle of the road, then this video is all about the traffic clearing team. This is a story of how modern medicine removes stones, crushes stones, bypasses stones, and prevents new stones from causing chaos again. It's a story filled with tiny cameras, balloons, baskets, lasers, shockwaves, sometimes even construction level surgery. Welcome to Cutting Strings. I am Gaurav. Let's begin. ERCP, Endoscopic Retrograde Cholangiopancreatography. That's a mouthful. It means looking into the bile and pancreas tubes with X-rays. It is a traffic controller of the bile duct world. It's the first line treatment in most centers for bile duct stones because it can see the stone and remove the stone in the same session. How ERCP works. A thin flexible tube with a video camera goes down the foot pipe and goes through the stomach into the duodenum or upper small intestine. A tiny catheter enters the bile duct. Dye is injected. X-rays show the stone. A small cut is made in the sphincter of Oddi with an electric knife. This cuts the one-way wall between the bile duct and the intestine. Stones are removed with a balloon or wire basket. What are the advantages? No skin cuts over the abdomen. It often requires a short hospital stay. It gives immediate relief from blockage. What are the risks? Acute pancreatitis. Yes, bile duct stones can cause pancreatitis, and ERCP, which is a procedure to get rid of bile duct stones, can also sometimes cause pancreatitis. Strange irony, bleeding. The cut site at the sphincter of Oddi can sometimes bleed more. Perforation. The duodenum or the first part of intestine can sometimes perforate during instrumentation. Infection. Cholangitis infection can happen. But for most people with bile duct stones, the recovery is smooth and the risk of not treating is far higher. Coming to more sophisticated tools. Peroral cholangioscopy. It's an advanced method that lets doctors directly look inside the bile duct, take targeted biopsies, and treat difficult stones that cannot be removed with standard ERCP alone. The most widely used modern platform is SpyGlass. ERCP uses X-ray shadows to locate the stones, but SpyGlass gives a direct camera vision inside the bile duct. It's literally a small spy camera for bile ducts. The technique is now used worldwide for complex biliary disease. However, its widespread availability, especially in smaller cities and towns, is still an issue. You see, these are costly gadgets, takes a toll on the hospital's budget. Lithotripsy is the plan B for stubborn stones, the stones that laugh at baskets and balloons. There are three main types of lithotripsy. Mechanical lithotripsy, done during ERCP. A small wire basket grabs the stone, a metal crusher squeezes it, the stone cracks, pieces are flushed out. Mechanical lithotripsy is like using a nutcracker on a cashew, which is stuck inside a narrow pipe. Electrohydraulic lithotripsy. A fine electric probe enters the bile duct, a tiny spark creates a shock wave. The stone shatters. It's used for very large stones, impacted stones, stones near strictures. It's basically a mini lightning bolt inside your bile duct, controlled by a doctor, not a superhero. Laser lithotripsy. An extremely precise pulsed laser is fired at the stone. Shock waves fragment it. This is also used for complex stones. Think of it as the lightsaber of stone removal. Both electrohydraulic and laser lithotripsy are usually done through direct camera vision, example SpyGlass, as shown in this picture. So the doctor can target the stone precisely. Extracorporeal shock wave lithotripsy. Shock waves are applied from the outside of the body that break the large stone, then fragments are removed later by ERCP. It was commonly used in the past and has been replaced by advanced tools nowadays. The key idea of this chapter is Lithotripsy is reserved for difficult bile duct stones that ERCP alone cannot remove. It's not a routine. Most people never need it. That's why I call it the plan B. Sometimes endoscopic tools like ERCP, SpyGlass and Lithotripsy cannot remove the stone because it's too large, it's impacted, the anatomy is tricky for endoscopy, or the stone is difficult to reach with endoscopy machine, or the stone is stuck in an awkward corner, or maybe the expertise is not available. And sometimes the technology itself is not available, especially in smaller cities and towns. That's when the surgeons step in, the construction crew of the bile system. The main surgical approaches are laparoscopic CBD exploration. Tiny cuts are made over the belly similar to laparoscopic gallbladder surgery. Using laparoscopic instruments, the bile duct is opened and the stones are removed using balloons and baskets, sometimes using a sophisticated camera called cholangioscope. With a direct camera vision, you can actually see the inside of the bile duct with the opening of its branches. The real-time view with yellow bile actively flowing out from liver is beauty. The cut on the bile duct is closed using sutures. Open CBD exploration. Used either when laparoscopic expertise is unavailable or the stones are too complex. A larger incision is needed, just like in open cholecystectomy surgery. It gives a direct access to the duct. These stones don't listen to reason. They are milked or pushed out manually after making a cut over the bile duct. Biliary bypass surgery. When stones form due to stricture or narrowing of the bile duct that jams the bile flow, a bypass surgery is needed. The narrow segment of the bile duct is bypassed by directly connecting the upper normal bile duct to a portion of the small intestine. This is similar to how a traffic bottleneck is bypassed by building a flyover. There are prerequisites and possible complications of these surgeries, just like any other. I won't dive into the specifics today. What about bile duct stents? CBDs or bile duct stents are like temporary pipes placed in the bile duct after ERCP or surgery to keep it open and let bile flow freely, especially if some stones are left behind or the duct is swollen. They look and work a lot like the plastic refill of a ballpoint pen. Both are thin, flexible plastic tubes with a smooth inner channel that lets fluid flow through without clogging. They prevent blockages, infections, and pain while the body heals or until a follow-up check removes them. They are usually taken out after 4 to 8 weeks once everything looks clear. Let's discuss a logical and systematic approach to bile duct stones. Step 1. How sick is the patient? Very sick patient with high fever, chills, very low BP. Treat as cholangitis infection. ERCP plus bile duct stent placement ASAP. Stable patient. Scanning first, then ERCP or surgery later. Step 2. Where is the stone likely to be? Only in gallbladder? Just laparoscopic cholecystectomy is needed. In both bile duct and gallbladder, usually ERCP first to clear the bile duct, then cholecystectomy. Step 3. If ERCP fails, what next? Surgical bile duct exploration. Step 4. What is available? This issue doesn't get much attention but actually holds more importance in the real world. The type of available technology, expertise, policy of the treating team, and sometimes personal preference matters. This is the core decision-making framework used worldwide. In real life, gallbladder stones and bile duct stones often live together, like two roommates. One makes the mess, the other dumps it in the corridor. Doctors usually follow a clear stepwise plan. Step 1. Clear the bile duct with ERCP. The bile duct is the main highway. If it's blocked, the whole system gets angry. ERCP removes the stone. Jaundice fades, blood tests improve. ERCP is like clearing a truck stuck in the middle of a busy highway. Step 2. Remove the gallbladder or cholecystectomy. Once the highway is clear, the next step is to shut down the stone factory. You may ask, why remove the gallbladder? because it keeps making stones. Some stones may slip into the duct again. How it's done? Laparoscopic cholecystectomy through small belly cuts, usually a few days or weeks after ERCP. In some centers, both are done in the same hospital stay, depending on the hospital's policy. Occasionally, stones at both locations can be handled surgically at the same time. So, in a suitable scenario, a single time procedure cures everything. People often ask, can't we just melt the stones? Wishful thinking. Let's understand how stone dissolving works. The drug is ursodeoxycholic acid or UDCA. It can sometimes slowly dissolve small cholesterol-rich gallstones that are inside the gallbladder. Why it doesn't work for bile duct stones? Bile duct stones' behavior is unpredictable. Stone dissolving takes months to years and only works with small cholesterol-rich stones. During this period, the risk of serious complications of bile duct stones like pancreatitis or cholangioscopy is too high. So far, we have talked mainly about stones in the common bile duct, which is the main highway. But stones can also form inside the liver itself, in the small branches of the bile duct or the intrahepatic bile ducts. Hepatolithiasis means stones in the bile ducts inside the liver. These stones often sit inside the branches of the ductal tree, like small roadblocks in side streets, not on the main highway. Now, why these intrahepatic stones are tricky? Because they are harder to reach with standard ERCP machine. They can cause local infections, repeated attacks of cholangitis, and long-term liver damage. Sometimes they are linked to strictures or narrowings and prior infections in the bile duct. So, what are the treatment options? Percutaneous transhepatic cholangioscopy. Instead of going into the main duct with an endoscope like in ERCP, a tube is inserted through the skin, through the liver, into the small bile ducts. That's how we directly enter the side streets. From there, doctors can see the stones and fragment or remove them with lithotripsy or baskets similar to what is done during ERCP, laparoscopic or open surgery. In some cases, surgeons may open the bile ducts inside the liver to remove stones. Sometimes, removing a portion of the liver, also called segmentectomy, is needed if the stones are packed into one side and the liver tissue that side is badly scarred. Long-term monitoring. Because new stones can form, doctors often repeat scanning and blood tests and may place stents or drainage tubes to keep the ducts open. If left untreated, stones within the smaller liver ducts have a tendency to develop cancer over time. This behavior is usually not seen with stones in the main bile duct. In short, common bile duct stones or cholangioscopy is the main road problem. Liver stones or hepatolithiasis is the side street problem, often more stubborn and sometimes needing surgery or percutaneous treatment. Myth busting time. This is where I separate fact from popular fiction. Myth 1. If I don't feel pain, the bile duct stone is not dangerous. Silent gallbladder stones can be harmless, but as I said before, bile duct stones are unpredictable and can block bile flow and cause cholangitis infection. They can also cause acute pancreatitis. They can scar the liver. Pain is not the only alarm, their mere presence is. Myth 2. If my stone is in the liver, it's no big deal. Intrahepatic stones can cause repeated cholangitis, destroy liver tissue, lead to long-term liver damage, and sometimes cancer. The main highway is most important, but the side streets matter too. Myth 3. Medication can melt the bile duct stones, so I don't need any procedure. As I discussed before, UDCA medicine can rarely be used for specific gallbladder stones, but it should not be used to cure any bile duct stone because of the randomness of complications. UDCA, however, is commonly used to prevent bile duct stones from forming, especially after bile duct procedure. The difference should be very clear. Trying to melt a bile duct stone is like melting an iceberg with winter sunlight while the ship is on course to hit it. Myth 4. I don't need a gallbladder removal surgery after the bile duct stones are taken care of. Most of the bile duct stones form and migrate from a deceased gallbladder. The gallbladder is the factory making stones, and the bile duct is the conveyor belt that they travel on. Removing stones from the duct clears the road, but unless the factory is removed, more stones will keep coming. Myth 5. After gallbladder removal, I can't get bile duct stones anymore. Now this is a twist. Removing the deceased gallbladder stops the stone factory. This was understood before. But the pipes or bile ducts remain as they are. The sphincter of OD normally prevents backflow of intestinal juices into the bile duct. Cutting it during ERCP to remove the bile duct stones opens a one-way valve both ways. The reflux of intestinal contents into the lower bile duct increases the tendency to form infection-related brown pigment stones in the bile duct up to 10 to 15%. Cholecystectomy kills the stone factory. Yes, but sphincter cutting during ERCP opens a sneaky backdoor for new stones. A 10 to 15% recurrence demands surveillance in high-risk patients. Bile duct stones may sound like a villain from a medical thriller, but modern medicine has them cornered. With ERCP as the trusty tow truck, lithotripsy as the stone pulverizer, and surgery as the ultimate road reconstruction crew, doctors can clear the highway of debris, demolish the stone factory, patrol the side streets, install permanent traffic controls. Next time you feel that ominous right upper abdominal pain, jaundice glow, or pancreatitis warning, rest easy. Your doctors wield sci-fi gadgets that would make James Bond jealous. And when they finally declare biryani is back on the menu, that's not just medical clearance, that's a victory lap material. Keep watching Gut Instincts for more content that breaks down complicated medical topics in a simple way. Share it with someone diagnosed with bile duct stones. Thank you for your time. Bye.